So what we're going to look at now is breaking CPR down into its separate parts. The first thing we're always going to do is check for dangers. Well, we're in the back of an ambulance for this filming, so there shouldn't be any dangers, but there might be. We've got oxygen and all sorts of stuff in here that we need to be careful of. But if you're in any other environment, danger comes first. My safety is critically important, because without me, the patient hasn't got a chance of survival if there's nobody else around. So safety comes first, so we check for dangers. There's no dangers, we then talk and tap, shout and shake to try and get a response. All we're trying to do is to rouse the patient. So once we've tried to get a response from the patient, the next thing we're going to do is check the airway. So we look inside the airway to look for things like false teeth or anything that might be blocking the airway, liquids, fluids, vomit, blood, anything that may give us an airway problem. Once we're okay with that, the next thing we're going to do is a head tilt chin lift. But first, we're going to drop the stretcher flat. We're going to roll a blanket under the neck, which will give us a natural position for the airway to open, and then we open the airway and check inside. Once we've decided the airway is clear, we're going to look, listen and feel for no more than 10 seconds. Listening for breath, feeling for breath on the face, watching the chest and feeling the chest rise and fall. No breathing, cardiac arrest. One thing we have to be careful of at this point is a thing called agonal gasping or agonal breathing. Agonal or agonal breathing is normally referred to as the last breaths of life. It is normally erratic, there is no pattern to it, it's deep, and it's noisy, sighing breaths. So they'll expand the chest, take a large breath and normally groan at the same time. They may take 2, 3 or 4. There's no real set pattern to it. It is completely random, deep, sighing, noisy breaths. This is not breathing and quite often gets mixed up for breathing. The patient then gets put into a recovery position and unfortunately CPR doesn't start and the patient's chance of survival drops dramatically. So be careful. Agonal gasping is important. The next thing that quite often happens to the patient initially in a cardiac arrest is the patient moves, and people expect a dead still patient, no movement whatsoever. But it is not uncommon, in fact it is very common, around 40% of all patients will move arms, they'll move the limbs, they'll twitch, they'll shake. Sometimes they'll put both arms up above the head, sometimes they will go vertical, but the patient will move. It is a natural reaction. It's nerve stimulus to muscle creating spasm, creating movement. This one gets mixed up and confused for patients that are fitting. It's a hypoxic fit, it's lack of oxygen to the brain that's creating this stimulus rather than an epileptic type fit created by nerve stimulus from brain activity. So this one's created by lack of oxygen stimulating the brain, whereas the other one can be created by numerous other reasons. Once we've eradicated both of those, we are now going to start CPR immediately. The faster we start, the better the outcome is going to be. So they're done very quickly, following on the back of each other. We identify the position, roughly nipple line. Palm of the hand goes in the centre of the chest, roughly nipple line. The fingers are linked and the fingertips are placed onto the chest. The fingertips form a hinge. They are never going to move. Even though the hand lifts and lowers, the fingers don't come off position. That means we're always going to be doing compressions in exactly the same place every time. One problem that people get is they start to bounce all over the chest. You're never in the same place twice. The heart's not moving, so you shouldn't be either. So once the position has been fixed, we fix the fingers to the chest, directly over the top of the patient, arms straight, and we now compress the chest 5 to 6 centimetres in depth, and then we fully recoil by lifting the heel of the hand off the chest. What we are doing by doing that is we are squashing blood from the heart and then allowing it to fully recoil and refill. Every time we do a compression, we have to allow the refill. The rate of 120 per minute is giving us the best flow rate of blood up to the brain from the compression. So once we start, we continue with the compressions. Notice with the arms locked, I'm not using muscle, I'm using body weight. Notice my hand never changes position, the fingers are fixed, and the compression to lift is a regular rate. If we do this correctly, we get good quality blood flow to the brain, giving the patient a much better chance of survival.